Do you hear me now, Dr. Khalid? So hello everyone, welcome to our last session of this year. My name is Mohammed Jamal. I'm a surgical resident in the Kuwaiti Board of General Surgery. I'm a member, organizer at Surge Kuwait. Today will be our last session of the bariatric series, Back to Basic. It will be a talk about the pathophysiology of the bariatric surgery given by Dr. Khalid Zaman. Dr. Khalid is a Kuwaiti Board General Surgery graduate. He did his fellowship in bariatric surgery in Brazil. He's currently working in Al Amiri Hospital. Welcome, Dr. Khalid. We're happy to have you on our platform.
Thank you. I'm happy to. Can you share this now?
Yes, please.
Okay. Can you see my screen now?
1 second. Can you try it again?
So share screen, then desktop 1.
Yes.
Keynote. Okay. How about now?
We're still not seeing it. I think now it's okay, perfect. So just before we start, for the audience, if you have any questions, you can please type them in the Q&A panel, and we're going to try to answer them towards the end of the session. Dr. Khalid, the mic is yours.
Hello, everyone. Good evening. I wanted to introduce myself to ease the pressure, but thank you, Dr. Mohammed. Today I'll be talking about bariatric surgery and how they work, because I could not reach to an agreement with Mohammed Hajia about the title. It's actually the physiology or the mechanism of action of bariatric surgery. How they work, and is bariatric surgery is the same that we know, restrictive and malabsorptive. So to start, obesity is the mother of all disease, as you all know. It is not a figure. It's not an outside satisfaction of your look. Actually, what we see outside is only the tip of the iceberg. It can cause diabetes, hypertension, and the rest of the metabolic syndrome, along with the increase in the cancer risk and overall survival. So why do you want to know about physiology? I remember when I started assisting in bariatric surgery 12 or 13 years ago, we used to go in and out from sleeve gastrectomies, and the only thing we understood back then is stabilizing the stomach. And then when I started doing the surgeries myself, and some of the fellow colleagues that I know, we continued the same. But then when we started reading more and more into the bariatric surgery, we understood that there are much more into it than what we know. So when we know physiology, we will understand obesity as a chronic disease, as a low-grade inflammation, and a disease that needs more than one-step surgery. In fact, it might need a non-surgical, surgical, and a long follow-up of the patient. Some of the patients might be lucky to finish with one step. Some of them might need 2 or 3. So the first thing, as I said, understanding obesity as a chronic disease. And then we understand the surgeries that we do, as I said, because we need to know that bariatric surgery isn't only a sleeve surgery. So here we're trying to convert from sleeve surgeons to bariatric surgeon by understanding the patho or the physiology. The common mistake that we all have is that understanding bariatric procedure as restrictive, malabsorptive, or combined. And this is wrong, because if these are the only description or classification of bariatric surgery, then why are we having the same response with different anatomy and different anatomic construct of the surgery? Sometimes we have patients with 11-meter intestine, some of them 5. But if you do the right surgery, you will get the right response despite the differences in anatomy. So, for example, the recent advances in researches found that the GI regulates the energy and glucose homeostasis. The GI and adipose tissue hormones, as we will see after, interact at the level of the hypothalamus to regulate the weight, energy intake, energy expenditure, and the food intake. So to start with, it's not as simple as cutting the stomach or diverting the GI system and then expecting the weight loss to happen the same way as restrictive, malabsorptive, and combined. So, for example, when we talk about malabsorption, we know that altering the anatomy will lead to weight loss. This will happen in form of fat malabsorption more than protein and carbohydrate absorption. And this is why the bariatric surgery will conserve the consumptive energy on the expenses of losing more fat as measured by the fecal fat percentage before and after bariatric surgery. But the question here, why would the patient have early satiety without a restrictive element? Which leads to the next question. We have different surgeries, as I said, and bowel length, but similar result. So if this is purely malabsorptive, or if the malabsorption plays 50 or 80% of the physiology of bariatric surgery, then how come the patient will have early satiety without restriction? So this is not the only explanation. If we go to caloric restriction, we know that in the immediate post-op, calorie restriction will play a big role in weight loss and glycemic control. But for how long? Because, again, different surgeries, different results. So if we compare diet versus bariatric surgery, actually, this is a research that was done comparing diet versus bariatric surgery. And they asked few patients to go on a preoperative and postoperative raw and white diet. So they found that the patient who went on diet would have the same early weight loss and insulin resistance improvement, but none of them had a long-term insulin resistance improvement. None of them had improvement in hepatic insulin sensitivity. And of course, none of them had a GI hormone alteration, which was seen only in raw and white patients. More than that, even regarding the weight loss, when you measure the weight loss between diet only and calorie restriction and bariatric patient, you will find that those on diet will need triple or more time to reach the same weight loss as the bariatric patient. As for energy expenditure, which is mostly the resting energy expenditure, we have, as we know, a diet adaptation that when somebody goes on diet and loses weight, the body will preserve the energy and fail the diet. And this is one of the main reasons why people going on diet might fail losing weight, because of this adaptation. And the results are conflicting regarding bariatric surgery. While some studies found an increase in resting energy expenditure, other researchers found the opposite result. How about changes in eating behavior? Would bariatric surgery changes our patients' eating behavior just simply by restricting their the stomach capacity of after eating. The facts here that patients after bariatric surgery, they prefer a lower fat and calories diet and stay away from a diet high in fat and calories. And if the question was this is due to restriction, we can answer that they can always compensate by finding other diet high in calories and small in volume, which is not the case here. The other thing that affect eating behavior or prove the idea of changing in our eating behavior is that when we compare the bariatric surgery results versus diet. Now we all know when you do sleeve and to a lesser extent Roux-en-Y and other surgery, you will have a lesser degree or a decrease in the level of ghrelin. While this is not what happens with diet. In fact, if somebody goes on diet, his ghrelin level will come up and will cause him to, he might break his diet. So what would be the reason? The taste acuity, they found that the taste acuity and the neural responses to food will change after bariatric surgery as measured by the functional MRI, which showed a reduction in the activation of the mesolimbic reward areas in the brain. So the patient would not be that happy when choosing food high in fat and calories. The third explanation would be the aversive symptoms, like in the patient after Roux-en-Y who go into or who will have dumping syndrome, and then the bad symptoms and that they will experience, which will steer them away from that kind of food. But unfortunately, this is a two-way complication because some patients might develop a maladaptive eating behavior, and that, in fact, will cause the opposite effect of eating a small volume but a high-calorie diet. The concept of intestinal adaptation, Entero-Hormones and incretin and anti-incretins. Talking about intestinal adaptation. Now, after Roux-en-Y, the physiology of Roux-en-Y will cause the elementary limb, as I wrote it in abbreviation AL. Elementary limb will undergo hyperplasia and hypertrophy. It will reprogram its cells into changing the way intestine will metabolize the glucose. There will be an increased uptake of glucose through increased receptor cells, and that in fact will be consumed only in the intestine itself, in the elementary limb. And this will help in the glycemic control because the net result of this will be the elementary limb will be like a glucose disposal site, and this is proven by PET scan. As for sleeve gastrectomy, it will lead to an increase in GLP cells, which will and a decrease in intestinal glucose absorption. The key word here is the entero-insular axis, and it's defined by the response, the GI response for the food in terms of endocrine, intestinal, and pancreatic hormones released in response to diet or to food intake. And the main hormones here or peptides are the GLP, GIP, the peptide Y, oxyntomodulin, cholecystokinin, and the Ghrelin. We will take them one by one to see their effect, and we will focus more on the GLP as it has the most pronounced effect in bariatric surgeries. So the GLP is produced by the L cells in the ileum and colon. It causes early satiety, and it has an insulinotropic effect in form of increasing the insulin secretion, decreasing its resistance. It augments the beta cell growth, suppresses glucagon, and one of the main and unique function of GLP that it decreases the gastric emptying and intestinal motility, which again goes back to early satiety. It also acts through a CNS pathway. Now, if we look at the characteristics of this peptide, we can see why, or we can see that it is the main acting peptide after doing malabsorptive surgery, what they call an ilealization of the proximal intestine. So by bringing the ileum more proximal, you're exposing the ileum to an early undigested food, which in turn will increase the GLP and all its beneficial effects. It is also enhanced after sleeve gastrectomy, although we're not diverting the GI system. And the reason would be that after sleeve gastrectomy, there will be an accelerated gastric emptying, and the degrading enzyme for the GLP is decreased. The next GI hormone is the oxyntomodulin, which is similar to GLP and also produced by the L cell. The glucose-dependent insulinotropic polypeptide GIP, it's produced from the K cells in the duodenum and proximal jejunum. It is an insulinotropic hormone, although not as potent as GLP, but it has no effect on motility, but a good effect on lipogenesis. The PYY, it acts similarly to GLP to some extent, causes an early satiety and glycemic control, and cause an gastric, slows the gastric emptying with the ileal brake mechanism. Most of the peptides, they share similar functions, but they differ in their potency, with the GLP is the most important one. The cholecystokinin is, as you all know, produced from the duodenum and proximal jejunum. It has a good glycemic control in terms of satiation signal and hepatic glucose production. Now, the famous peptide that we all learned about many years ago doing sleeve gastrectomy or assisting in one. It is produced from the oxyntic gland in the fundus and smaller amount in the small bowel. It's a growth hormone releasing peptide, which means it is an orexigenic hormone acting on the hypothalamus. It increases the appetite. At the same time, it has an anti-incretin effect, so it is bad for insulin. In the obese patient, they found they have a decreased suppression of ghrelin even after a meal. And this is where the sleeve gastrectomy would be good for such patient, because decreasing the ghrelin would lead to good results in terms of metabolism. So now moving forward towards a mechanism of diabetes resolution. What we know, of course, that insulin resistance is a main cause. We also know that caloric restriction and weight loss are not the only solution. They play a big part, but are not the only solution. Why? Because improvement and resolution usually precede weight loss. So the improvement in glycemic control would be faster than the weight loss seen in bariatric surgery, which leads us to the conclusion that there are more into glycemic control than weight loss. It also differs between the procedures. The effect, the improvement and the resolution. So even if a patient would go for Roux-en-Y or mini gastric bypass, the diabetes would be, if not the same, maybe better than sleep gastrectomy, even if they lose the same weight. So there is something more into this than weight loss. So we go back to Entero-Hormones again. There are two hypotheses to explain diabetes improvement after bariatric surgery, the Foregut and the Hindgut hypothesis. The Foregut hypothesis focuses on duodenal exclusion, but has two explanations for the diabetic control after that, or improvement. The duodenum is responsible for secreting anti-incretin substances, so anti-insulin. Decrease the insulin secretion, increase the insulin resistance, and the beta cell mass depletion. So working on animal, they found that duodenal exclusion will improve glycemic control, and when you reverse this exclusion, the glycemic control will be impaired again. Another explanation for glycemic control after duodenal exclusion, that this will lead to a decrease in glucose absorption by two mechanisms. First, intestinal morphology, which will change, having a taller villi and a deeper crypt, but at the same time, less absorption, probably due to sodium glucose co-transporter function. The Hindgut hypothesis, it talks mainly about the GIP and GLP that we talked about, the presence of undigested food, or the early presence of the food in the distal small bowel will initiate the incretin effect, which is a good insulinotropic effect. So this is probably a more convenient theory behind or explaining diabetes improvement after bariatric surgery. Now for the neuroendocrine mechanism, the thing that I learned, and I want you all to learn, is for those who do not know, the axes that exist between the gut and many vital organs. We are looking now at the neuroendocrine, the gut-brain axis, and later on we will see the one with the heart and the kidney. So it is not something locally happening in the stomach. It is not something only with the brain modifying appetite or glycemic control, but it is connected to all the vital organs in the body. So now the gut-brain axis, the GI hormones have direct effect on controlling the glycemic, the glucose metabolism, versus by vagal endings. So acting the GI hormones direct effects on the brain through the bloodstream versus acting on the vagal endings through signaling and stomach distension, as you will see now when we go to the vagus stimulation. The gut-brain axis is responsible of regulating the energy balance, and ultimately it influences the body weight and the glucose regulation. The vagus nerve has some interesting role in weight loss and glycemic control, but I did not want to bother you with the explanation about its connection and role in the brainstem. But in general, it leads to early satiety and glycemic control as the rest of the mechanism that we explained earlier, but each one of them does that in its own way. So for the vagus nerve, it does that by the distension of the stomach and the presence of nutrient in the raw limb will initiate the anorexigenic pathway. Problem here, this window is covering the presentation on the other side. There is also a reorganization of hindbrain feeding circuits. So this is their way, or this is the way of the vagus nerve modulation of glycemic control and satiety after bariatric surgery. Bile acids. Bile acids usually increases after bariatric surgery, namely Roux-en-Y and biliopancreatic diversion. It is involved in the Hindgut hypothesis and bile. It is involved in the Hindgut hypothesis in a way that I will explain now. When bile acid is recognized by TGR and farcinoid or FXR receptor in the liver, it will activate the L cells. And this will go back to what we were saying about the GLP. It also affects the liver glycogenesis, inhibiting gluconeogenesis, and it will ameliorate insulin sensitivity. And it has a positive alterations on the feeding behavior. The GI microflora, here we reach the colon to see how many organs are involved in the effect of bariatric surgery, positively or negatively. So the gut flora participate in metabolism. When we have the bacteroidetes and firmicutes, those are the main population of the colonic microbes. But in obese patients, changes in dominant bacteria, namely the firmicutes, will lead to adiposity. How? In form of increasing energy harvest. In bariatric surgery, this will be shifted back toward lean ones. There is also some researches about probiotics and trying to change the colonic environment, even by fecal transplant. It came with good results in animal and in 2 or 3 patients in one small study, but it was not a long-term result. Moving forward toward adipose tissue, and this is very important part of mechanism of action of bariatric surgery. The peripheral fat will lead to, the more peripheral fat a patient has, means more insulin resistance. This is for the peripheral fat. For the visceral fat, they produce pro-inflammatory cytokines and reduces anti-inflammatory cytokines, like the adiponectin. One of the modulators that is linked between the adipose tissue and the gut regulation of body weight is the omentin 1, which is a very important modulator of insulin sensitivity. It increases the insulin sensitivity and decreases the insulin resistance. This is decreased in obese patient, and after bariatric surgery, it will increase. Leptin is a hormone found in white adipose tissue, mainly the peripheral and skeletal, white adipose tissue, and gastric mucosa. Gastric mucosa will release leptin in response to food. This leptin will act, it crosses the blood-brain barrier. It will act at the level of the hypothalamus, controlling appetite and energy expenditure. When it decreases, it will lead to an increase in hunger and lipolysis. And reduction is reported in all the bariatric procedure, which leads to weight loss, probably by the lipolysis that it causes after reduction. Adiponectin causes insulin sensitivity and fatty acid oxidation. So when it is low, the insulin resistance will increase, and so will the coronary artery disease. It is decreased in obese and will increase with weight loss. It decreases TNF, it decreases many inflammatory cytokines like TNF. And when it does, it will decrease the monocyte adhesions to the endothelial cells, which will lead, of course, to atherosclerosis. The beta cell changes. I think this is one of the most important slides in the presentation because it talks about a very important point in diabetes resolution after bariatric surgery, because the residual volume of the beta cell is very important in glycemic control after bariatric surgery. And this is why we see the changes in diabetic in those with diabetes type 2 and not type 1. So in order for diabetes to improve or be cured, the shorter the course of the disease, the lesser beta cell dysfunction, the better the outcome of the bariatric surgery in terms of curing or ameliorating the diabetes. The pancreatic islet cell histopathology changes after Roux-en-Y, for example. There will be a regeneration and hypertrophy, notch signaling, which is a cell-to-cell signaling leading to cell protection and repair. There will be reduced fibrosis. And last but not least, beta cell glucose sensitivity will increase. The effect in type 1 is somehow controversial because there is a small report about few patients who improved after bariatric surgery despite having less beta cell residual mass. Now, the cardiac response to obesity and bariatric surgery. In obesity, the excess energy will be stored into adipose tissue. When the capacity is exceeded, the storage will be ectopic. Ectopic means in non-fatty organs. This will lead to lipotoxicity. When the fatty acid is utilized by the heart as a fuel, there will be a decreased mechanical efficiency and increase in the cardiovascular risk. And this is why bariatric surgery will always reduce the metabolic load and stress, and thus reduction of cardiac load. The GI renal axis, and this will explain the good effect on the kidney and the hypertension per se. The GI hormones affect renal function in terms of mainly in sodium excretion. The GLP in specific has a natriuretic effect. There will be an increase in GFR by this mechanism. The afferent arterial resistance will be reduced, mainly by the nitric oxide vasodilation characteristics of the GLP. There will be an increase in the afferent arterial resistance and so reduction in Bowman space pressure. This will all lead to an increase in GFR. The net result will be a less chance or prevention of chronic kidney injury. So to conclude, my take-home message, bariatric surgery is not a plastic surgery. What we see from the outside after the surgery is only the tip of the iceberg of the big improvement that they have inside. Bariatric surgery is the most effective method of a sustained weight loss, a long-term weight loss, and improvement or even cure of major diseases. And if not, at least with bariatric surgery, you will have less end organ damage. So I think it is more than eat less and exercise. And the advice is that sometimes we hear even from our non-surgical friends. And I hope after this presentation, we have more insight of what we're doing. And thank you.
Thank you very much, Dr. Khalid, for this informative lecture. Now, if the audience have any questions, please feel free to type them in the Q&A panel.
Where can
Thank you, Dr. Khalid. So far there's no questions. We can give them 1 minute just to see if anyone want to ask any question. All right, looks like it was a very informative session, Doctor. There's no questions from the audience. Thank you so much for joining us today. We know it was difficult for you to join in the previous session, but you made sure to join us today. So thank you, Dr. Khalid.
Thank you.
Thank you, everyone.